Next, you can have venous hypertension, which can be systemic or local. So systemic cause of a venous hypertension would be 3 causes: cardiac failure, liver failure, renal failure. In cardiac failure, usually the effusions are bilateral and small with an associated enlarged heart or cardiomegaly. Liver failure, usually it is going to be right-sided in about 85% of the patients. Left-sided effusions you can get in 15%. So whenever you have it only on the right side, you call it as a hepatic hydrothorax. Okay. So whenever you have hepatic hydrothorax, how are you going to manage? We'll quickly see this here itself. So hepatic hydrothorax, you are going to do a drainage. Okay, you can do a pleural thoracocentesis. Never try to put a chest room in these patients. You just do a thoracocentesis and drain as much as possible and treat the underlying cause. Treat underlying cause. So this is with respect to your liver failure. So if sometimes you may not be able to do it. So let us say sometimes there is a refractory cause. So then you treat like a large volume paracentesis you add a diuretic, you add other substances, the vasoactive substances. Despite that it is not improving, then you can do a TIPS. But problem with TIPS is it can worsen your hepatic encephalopathy. So if you're having a liver failure patient, tipping him into a HE is very dicey. So what you do, the other option is, although the evidence for this is not very great, there are very few case series and reports that are there. There's a consensus paper that is there. You can do an attempt of an IPC. You will see what is an IPC in the subsequent slides. So this is what is called as an indwelling pleural catheter. So you'll have a catheter inside the pleural space and you can drain whenever you feel like draining. And plus minus, you can do a talc pleurodesis. So when you're putting a catheter, put a talc agent. Once the lung is expanded, and you can use this. Whereas there is high risk of infection of the pleural catheter also. This is one thing that you should remember. Then you have renal failures. So in renal failure, very interestingly, you can have in 2 ways. So it can be a transudative or it can be an exudative. Exudative, it is because of a uremia. Transudative, it is because of your volume more. So both can be there. So it is very important to distinguish these two. Next. Local cause, you have pulmonary embolism. Very important. 15% of pulmonary embolism can come with a transudative effusion, that is because of your lymphatic obstruction. And whenever you have a unilateral effusion, which is transudative, and patient is still hypoxic, you have to rule out a pulmonary embolism unless proven otherwise. So that is one poll that you will take back. Hypoxemic unilateral transudative effusion is P until proven otherwise. Next, you can have SVC syndrome and dialysis access related. So this